Yeah, good morning, students. Now let's continue with the heme chemistry. So yesterday we were discussing about the we have started discussing about structure of heme. There you know that hemoglobin is composed of heme, prosthetic group, and globin, that is protein part. And you know the structure of the globin, structure of the heme, how it will be. Heme is a iron containing porphyrin ring which has 4 pyrrole rings. Okay, these are the pyrrole rings. Those pyrrole rings has been attached by methylene bridges. Okay, and these are the methynyl bridges. Now here, and this each pyrrole group is substituted with the groups like methyl, vinyl. So like that, total 8 substituted groups have been attached to 4 pyrrole groups. Now here, this is the tetrapyrrole structure. At the center of the heme, iron occupies in Fe+2, which has 6 valencies. 4 valencies has been occupied with the has been connected to 4 valencies has been connected to nitrogens, 5th one to proximal histidine of globin, and 6th one to oxygen. Okay, that is the structure of oxyhemoglobin. Suppose in place of oxygen, if water is there, that you can call it as deoxyhemoglobin. So that is the structure of heme. And globin, we know that globin is a protein part. It has 4 polypeptide chains, 2 are of alpha type and 2 are beta, and each polypeptide chain at the center has having heme pocket where the heme is binding. So one molecule of hemoglobin has 4 polypeptide chains, so it has 4 units. So that's what, and each heme unit has 1 iron at the center, carries 1 oxygen. So one molecule of hemoglobin can carry 4 molecules of oxygen. This we have already discussed yesterday. So this is the structure of the hemoglobin. Just look at this one. These are all the these spiral knots are the polypeptide chains. Like that, how many are there? 4 are there. So at the center of each polypeptide chain, so these are the 4 polypeptide chains, maybe of alpha type, beta type, gamma, etc. And these for each polypeptide chain has center, there is a heme pocket. Red one is the heme pocket. In that heme pocket, the heme lies over there. At the center of the heme, there is iron in Fe+2 that can transport oxygen, that can carry oxygen. So like that, in one hemoglobin molecule, there are 4 heme units are there, so that can able to carry 4 oxygen molecules. So that is the structure of hemoglobin. And even more clear here, this is the, okay, see here, these alpha chains and beta chains are connected by ionic bonds, non-covalent bonds, and they are so to attain the quaternary shape of the hemoglobin. This is the quaternary shape of hemoglobin, which has 2 alpha chains, okay, and 2 beta chains. Alpha and beta chains are well connected by ionic bonds. At the center of each polypeptide chain, there is a blue ones are pockets, heme pockets, where heme is present. Inside of the heme, iron is present. So this is the structure of hemoglobin. Now coming to the types of hemoglobin. So different types of hemoglobins have been identified based on the type of the polypeptide chains present. Okay, that means in all the types of hemoglobin, heme is similar. Okay, and there are 4 polypeptide chains are there, but they may be different in their combination of polypeptide chains, because the 4 polypeptide chains which participate in the structure of heme may be of alpha, beta, gamma, delta, epsilon, or zeta type. Okay, heme is common. That heme could be bind to the globins. There are different types of globin chains are present. Alpha chains, beta, gamma, delta, epsilon, or zeta. These are the different types of polypeptides. The total 4 will be there, but the combination of these 4 will be there. Okay. So there are mostly 2 alpha will be there out of 4. In most of the hemoglobins, 2 are of alpha. Other 2 may be beta, gamma, or delta, etc. Okay, so different types of hemoglobins are HbA, HbA2, A1, A1C, HbF. Okay, these are the different types of hemoglobins. Now, adult hemoglobin, HbA, A for adult, that is adult hemoglobin, which contains the 4 polypeptide chains here in the structure of adult hemoglobin are 2 alpha, 2 beta. 98% of the hemoglobin which is present in the blood is of adult hemoglobin. So adult hemoglobin has three types: HbA1, A2, A1C. Okay, 98% of the hemoglobins are of HbA type. Under HbA, you have different types of HbA are there based on the composition of the polypeptides, that is HbA1, A2, A1C. Now A1 is composed of, it's one of the type of adult hemoglobin. 90% of the hemoglobins are of HbA1, which is composed of 2 alpha and 2 beta. Next one is HbA2, and its concentration it constitutes less than 5% of the total hemoglobins, and it is composed of 2 alpha and 2 delta. Next one is HbA1c, here composed of 2 alpha and 2 beta along with the carbohydrate, that is glucose, and its concentration is less than, HbA1c concentration is less than 5% of the total hemoglobin. Now the other type of hemoglobin is HbF. HbF is fetal hemoglobin. Its concentration is less than 2%, okay, and here it is composed of 2 alpha and 2 gamma. So look at this here, in all the different types of hemoglobins, 2 polypeptides are of alpha type only. Difference occur in the other 2 polypeptide chains. Other 2 may be beta, delta, gamma, etc. Now here coming to the HbA2. So that till now what we have discussed in the previous class, that is structure of hemoglobin, that is nothing but the structure of hemoglobin A. Okay, that means hemoglobin A1 is composed of like normal hemoglobin. 90% is of HbA1 composed of 2 alpha and 2 beta. That you know the structure. Then coming to HbA2. A2 is which constitutes 2% of the total hemoglobin, and HbA2 is composed of 2 alpha and 2 delta. Okay, HbA1 has 2 beta. In place of beta HbA2, 2 delta chains are present. And so the homology, amino acid sequence of the delta is almost similar with that of beta chain. And here its isoelectric pH, okay, HbA2 being a protein, its isoelectric pH is 7.4. But HbA1 isoelectric pH is 6.85. So that's what HbA2 is, slow in moving on electrophoresis. Okay, these different types of hemoglobins you can separate. Okay, different types of hemoglobins can be separated by electrophoresis. Electrophoresis means you know the principle, movement of the charged particles under electric field. Now here, as the here isoelectric pH of this HbA2 is 7.4, okay, that is the more than the pH, that is isoelectric pH of HbA. So that's what HbA2 is slower moving on electrophoresis. And the next one is here HbA2. Its concentration is increased. Normally it should be less than 2. Its concentration is increased in beta thalassemia. Okay, that's it about HbA2. It is one of the type of adult hemoglobin composed of 2 alpha and 2 delta. And its isoelectric, its pI is 7.4. It has slow movement under electrophoresis when compared to HbA. And its concentration is increased rapidly here in beta thalassemias. So that's it about this HbA2. Then coming to the next one is HbA1c. HbA1c is also called glycosylated hemoglobin. HbA1c is also called glycosylated hemoglobin. Here hemoglobin exists. Why it is called glycosylated hemoglobin? Means hemoglobin in combination with the glucose. So here hemoglobin exists in bound form with the glucose. Okay, hemoglobin is present in combination with the monosaccharide, that is glucose. And here the addition of the glucose to this hemoglobin occurs spontaneously, non-enzymatically. Okay, so glucose has been added to hemoglobin. The process occurs spontaneously, non-enzymatically. So how the glucose has been attached to hemoglobin means, okay, aldehyde group of glucose. Okay, glucose is a aldohexose. Aldehyde group lies at the C1. So aldehyde group of glucose that reacts with the amino group of N-terminal residue of beta chains. Okay, beta chain is a polypeptide chain. You know that each polypeptide chain there is C-terminal and N-terminal. So this glucose aldehyde group of glucose has been attached to N-terminal amino acid of the beta chains to form a glycosylated hemoglobin. Concentration of HbA1c is less than 5%, and HbA1c has clinical significance. Okay, the estimation of HbA1c in the blood has clinical significance because the formation of HbA1c is proportional to blood glucose concentration. Okay, see here HbA1c, its blood concentration, it should be less than, in normal healthy individuals its concentration should be less than 5%. But here it has, the estimation has the clinical diagnostic importance because the formation of HbA1c is directly proportional to blood glucose concentration, and it also provides information about dynamic changes occur in the blood glucose levels. Now here the levels, HbA1c levels are increased in diabetes mellitus.
ఇది కనెక్షన్ పోయింది
చూసాను
ఒక్క ఉండండి కూర్చోండి ఒకసారి
Okay, now here again I repeat, HbA1c, that is called glycosylated hemoglobin. Why? Because here hemoglobin has been connected to, is in bound form with the glucose. Aldehyde group of glucose has been joined to amino group of terminal amino acid from the N terminal of beta chains to form glycosylated hemoglobin. Its concentration is less than 5%, and formation of HbA1c is directly proportional to blood glucose concentration. Okay, and it provides, the HbA1c concentration provides information about the changes occurring in blood glucose levels. And as diabetes mellitus, it is characterized by hyperglycemia, increased blood glucose levels. So HbA1c levels are increased in diabetes mellitus because formation of HbA1c is proportional to blood glucose. As in diabetes mellitus, there is increased blood glucose levels, so that increases HbA1c. And here in HbA1c, sometimes it may be, normally it should be less than 5%, sometimes it may reach up to 12% more of the total hemoglobin. And here estimation of HbA1c, it provides us the information useful for management of diabetes mellitus. Okay, see here, after prescribing the proper drugs, how the patient's blood glucose levels has been maintained. So management of diabetes, it gives estimation of this HbA1c, gives us the information about the management of diabetes mellitus. So how actually this HbA1c, it gives us the average blood glucose levels over a period of 3 months. Okay, see here how could this HbA1c helps in management of diabetes mellitus means, because it reveals, HbA1c gives us the information about average blood glucose levels over a period of 3 months. Why? How it will give average blood glucose levels of past 3 months means, because HbA1c, this one is has been attached to RBC. So lifespan of RBCs is 120 days. So HbA1c gives, after 120 days RBCs are destroyed and HbA1c is released. So it gives the average blood glucose levels over a period of 3 months because the lifespan of RBCs is 120 days. Normal values of HbA1c is, in normal healthy persons, it should be in between 4 to 5.6. If the value is in between 5.7 to 6.4%, they are pre-diabetic, prone for diabetes. And if the value is more than, HbA1c concentration is more than 6.5%, that indicates diabetes. Okay, that is the importance, clinical significance of this HbA1c. HbA1c is one of the type of adult hemoglobin. Okay, here HbA1c is composed of what? like a adult hemoglobin composed of alpha and beta, but here glucose has been attached. Okay, so that's it about here. And please here concentrate here. It gives the blood glucose levels over a period of 3 months, average blood glucose levels over a period of 3 months, because once glucose is attached to hemoglobin, it cannot be released back into the glucose. So after the lifespan of 120 days, this will be released into the blood, and that like that it gives the average blood glucose levels over a period of 3 months. Okay, that's it about your HbA1c. The next one, other type of hemoglobin is HbF, that is called fetal hemoglobin. And fetal hemoglobin is composed of 2 alpha and 2 gamma chains. Especially it is formed during the fetal life. Okay, this HbF type is formed during the fetal life. It is composed of 2 alpha and 2 gamma chains. Normally HbF, its synthesis starts by 7th week of gestation, and predominantly its maximum level reaches by 28th week of pregnancy. And at the time of the birth, 80% of the hemoglobins are of HbF type. Okay, so this HbF mainly present during the fetal life, and its synthesis starts by 7th week of gestation and predominate by 28th week. Now, at the time of birth, if you see, 80% of the hemoglobins are of which type? Fetal, HbF type. And first 6 months after birth, within the first 6 months of life, HbF concentration decreases to 5%. At the time of the birth, 80%, but within 6 months only, the concentration is decreased to 5%. But sometimes HbF levels remains high in children, in infants with anemia and beta thalassemia as a compensatory measure. Okay, so in normal healthy infants, the level of HbF should be dropped up to 5% in first 6 months only. At the time of birth, 80%. But after 6 months also, if HbF levels remain high, means that indicates anemia or beta thalassemia. Now here, how this HbF usually first it is during embryogenesis. First it is composed of 2 zeta and 2 epsilon. Okay, from its synthesis starts from 6th week of gestation. First it is composed. Initially it is composed of 2 zeta polypeptide chains and 2 epsilon. And the next, during the second trimester, by the reaching the 6 months, so this zeta and epsilon has been replaced by 2 alpha and 2 gamma. Okay, at the time of first, here it is synthesized as 2 zeta and 2 epsilon, and at the end of the second trimester, 2 zeta 2 epsilon has been replaced by 2 alpha and 2 gamma. That is the composition of hemoglobin F, that is fetal hemoglobin. And after birth, 2 alpha remains like that, but gamma has been replaced by beta, forming the adult hemoglobin, that is HbA1. I think you are following. Okay, see, fetal HbF is found only during the fetal life. Its synthesis starts from 6th week of gestation. Initially, it is composed of 2 zeta and 2 epsilon. And after the second trimester, this 2 zeta and 2 epsilon has been replaced by 2 alpha and 2 gamma. So that is the composition of fetal hemoglobin. And after birth, after 6 months, up to 1 year, so this alpha remains like that, and gamma has been replaced by beta. That will become the adult hemoglobin, that is HbA1. Okay, and so this HbF, it completely disappears from blood in first year of life, but its persistence after first year is considered as abnormal. Okay, in normal healthy children, at the time of the birth, 80% of the hemoglobins are of HbF, and after 6 months that 80% is reduced to 5%, and at the end of the 1 year, all HbF has been completely replaced by HbA1. Okay, still there is some persistence of high levels of HbF even after first year, so that is considered as abnormal. Maybe beta thalassemias, maybe the child may be suffering from beta thalassemias, anemia, etc. Now, what are the characteristics of HbF is it increases the solubility of deoxyhemoglobin F, and say here this HbF has lower electrophoretic mobility, and here it increases the resistance of hemoglobin F to alkali denaturation. Okay, hemoglobin F increases the resistance to alkali denaturation. An important property of HbF is it has decreased interaction with the 2,3-BPG. Okay, 2,3-BPG is a compound. It has more affinity. Hemoglobin, normal hemoglobin has more affinity towards the 2,3-BPG, whereas HbF, fetal hemoglobin, has less affinity with the 2,3-BPG. Okay, because of this property, okay, as it is having less affinity towards the 2,3-BPG, this property help in transferring maternal blood from mother to fetus. Okay, so this property help in, as it is having high affinity for oxygen, and that is as it is having low affinity for 2,3-BPG, helps in supplying more oxygen to the fetus. That's it about the one other type of hemoglobin, that is hemoglobin F. Now look at this here. These are the different types of hemoglobins: HbA1, A2, F, A1C. A1 is composed of 2 alpha, 2 beta. HbA2 is composed of, its total percent of HbA1 concentration is 90% of the total hemoglobin. So maximum hemoglobin are of HbA1 type. Less than 5% are of HbA2, composed of 2 alpha and 2 delta 2. HbF is fetal hemoglobin. Okay, it's here it is composed of 2 alpha and 2 gamma. Here its concentration should be less than 2% of the total hemoglobin, and other one is glycosylated hemoglobin, that is HbA1c, composed of 2 alpha, 2 beta along with glucose. Its concentration in healthy person should be less than 5%. Okay, and here next one. Okay, and then the next one is that's it about the types of hemoglobins. Now coming to the next one is hemoglobin derivatives. So derivatives of hemoglobins means till now we have discussed about the structure of the hemoglobin and hemoglobin. Then we have discussed about the types of hemoglobins like like HbA1, A2, A1C, HbA. Then coming to the next topic, then we move on to the next topic, hemoglobin derivatives. So what are these derivatives? How they have been formed means these derivatives have been formed by changing the oxidation state of iron. Okay, these derivatives have been formed by changing the oxidative state of the iron, or by changing the combination by the addition of different ligands to the heme part. Okay, I repeat here, hemoglobin derivatives, they have been formed by combination of different ligands with the heme part. It means different addition of the extra groups to the heme part, or by changing the oxidative state of the iron. Okay, now these hemoglobin derivatives are of two types: normal hemoglobin derivatives and abnormal hemoglobin derivatives. Okay, normal hemoglobin, there are two types. Okay, here in the derivatives only there are two types are there: normal and abnormal hemoglobin derivatives. Just let us discuss about the normal hemoglobin derivatives. So these normal hemoglobin derivatives are oxyhemoglobin, reduced hemoglobin, carbaminohemoglobin. Okay, normal HB derivatives are oxyhemoglobin, reduced hemoglobin, carbaminohemoglobin. These are the normal derivatives. And I repeat, how they have been formed: by the addition of the other groups or by changing the oxidative state of the iron. Now here, first one is oxyhemoglobin. Oxyhemoglobin means here this is formed. Okay, oxyhemoglobin is formed by the combination of hemoglobin with the oxygen. Okay, see here, oxyhemoglobin. This is formed by the combination of hemoglobin with oxygen by oxygenation. Okay, that means addition of oxygen to the hemoglobin to form oxyhemoglobin. Okay, so you know that as hemoglobin has 4 polypeptides are there, it four heme pockets are one hemoglobin has 4 heme units. So one molecule of hemoglobin can combine with the 4 oxygen molecules to form oxyhemoglobin. Okay, this is oxyhemoglobin, but this oxyhemoglobin is unstable. Immediately it is converted back to reduced hemoglobin, but in both the states iron remains in Fe+2 form. That's it about the oxyhemoglobin. Oxyhemoglobin means here it hemoglobin with the oxygen by oxygenation. Okay, that means oxyhemoglobin is formed by the combination of hemoglobin with the oxygen. Okay, one molecule of hemoglobin can combine with the 4 molecules of oxygen to form oxyhemoglobin. Oxyhemoglobin is an unstable compound. It is converted back to reduced hemoglobin. and iron remains in Fe+2 form. Then the next form of normal hemoglobin derivative is reduced hemoglobin. When oxygen is released from oxyhemoglobin, it is called reduced hemoglobin. Okay, from oxyhemoglobin, if oxygen is released, that is to form reduced hemoglobin. And here, next one is carbaminohemoglobin. Carbaminohemoglobin means it is a derivative of hemoglobin with carbon dioxide. It's a derivative of hemoglobin with carbon dioxide. Now here, carbon dioxide can be easily released from this because the affinity of the hemoglobin with carbon dioxide is 20 times more than for oxygen. Okay, so carbaminohemoglobin means just it's a hemoglobin derivative, hemoglobin along with the carbon dioxide, and affinity of the hemoglobin with the carbon dioxide is 20 times more than for oxygen. Okay, these are the normal derivatives: oxy, reduced, carbaminohemoglobin. Okay, and here the next one, so that means deoxyhemoglobin is hemoglobin without oxygen is called deoxyhemoglobin. Hemoglobin with oxygen is called oxyhemoglobin. Try to differentiate. Hemoglobin without oxygen is deoxyhemoglobin. Hemoglobin with oxygen is oxyhemoglobin, and hemoglobin with carbon dioxide is carbaminohemoglobin. So that means carbon dioxide is bound to the globin chain, and about 15% of the carbon dioxide is transported in the blood in the form of carbaminohemoglobin. Carbaminohemoglobin is nothing but hemoglobin with carbon dioxide. And the next one is carbonyl hemoglobin, that is hemoglobin with the carbon monoxide. So first here, this is the abnormal one. These three are the normal ones. Deoxyhemoglobin, that is reduced hemoglobin, hemoglobin without oxygen, oxyhemoglobin, hemoglobin with oxygen, carbaminohemoglobin, that is hemoglobin with CO2. And this hemoglobin has the affinity of the hemoglobin with the carbon dioxide is 20 times more than for oxygen. Now coming to the next one, abnormal hemoglobin derivatives. So abnormal hemoglobin derivatives are methemoglobbin, sulfhemoglobin, and carboxyhemoglobin. Abnormal hemoglobins are methemoglobin, sulfhemoglobin, and carboxyhemoglobin. This is carboxy means COHB. Now, what is this carboxyhemoglobin? Carboxyhemoglobin means hemoglobin with carbon monoxide to form carboxyhemoglobin. Carbaminohemoglobin means hemoglobin with the carbon dioxide. Now here the abnormal hemoglobin derivative is carboxyhemoglobin, that is hemoglobin with carbon monoxide CO to form carboxyhemoglobin. And what is this carboxymonoxide? CO is a colorless, odorless, tasteless gas which is generated by incomplete combustion. Okay, CO2 is a compound produced by industrial pollution, automobile exhaust, and incomplete combustion. Okay, this CO2 is a colorless, odorless, tasteless gas. It is produced mainly by automobile exhaust, incomplete combustion, and the industrial pollution. This carbon monoxide is poisoning. Carbon monoxide poisoning is a major occupational hazard for workers, for those who work in mines. And breathing the automobile exhaust is in closed space is the commonest cause for carbon monoxide poisoning. Okay, see now I'll explain you why this carbon monoxide is poisonous. So here this is the gas released by incomplete combustion. So that carbon monoxide combined with the hemoglobin to form carboxyhemoglobin. Now this carboxyhemoglobin is unsuitable for oxygen transport. It cannot transport oxygen, and the main important one property see here is carbon monoxide. Affinity of the carbon monoxide with Hb is 200 times more than that of oxygen. Okay, please note down here. So this is due to automobile exhaust released into the air due to automobile exhaust and incomplete combustion. This carbon monoxide which is there in the air has 200 times. Okay, the affinity of the carbon monoxide to hemoglobin is 200 times more than that of oxygen. So that means even because of the high affinity, even small concentration, small amount of the carbon monoxide in the inspired air, that causes the formation of large amount of carboxyhemoglobin. And as I mentioned, this carboxyhemoglobin is unsuitable for oxygen transport. It reduces the oxygen carrying capacity of the blood. I repeat here, carbon dioxide which is released into the air, so that has a more affinity towards the hemoglobin. Hemoglobin has more affinity towards the carbon monoxide. That's what the small concentration of the carbon monoxide in the inspired air causes the production or formation of large amounts of carboxyhemoglobin, and that carboxyhemoglobin which in turn reduces the oxygen carrying capacity of blood. Now here, so even 1% of carbon monoxide in inspired air is fatal. Sometimes it may lead to death. In normal healthy persons, in non-smokers, there is less than 2%. Okay, this carboxyhemoglobin concentration in normal healthy person, in non-smokers, it is less than 2%. In chronic smokers, the concentration of COHB exceeds more than 5%. This COHB, if it exceeds 20%, that could be poisonous and cause breathlessness, headache, nausea, vomiting, chest pain. See here, the normal, even small 1% of the CO2 in the inspired air, okay, that may be fatal. Normal healthy person should have less than 2% of COHB. In smokers, okay, non-smokers. In smokers, the value should not exceed more than 5%. But here, sometimes the CO levels, if it exceeds to 20%, it causes carbon monoxide poisoning, causes breathlessness, headache, nausea, vomiting, chest pain. And if the concentration of COHB exceeds, if it is more than 40%, it would be fatal. Okay, why? Why this increase in the concentration of the carbon monoxide, which causes all these symptoms and sometimes it leads to death, means because, as I mentioned, carbon monoxide has more affinity towards the hemoglobin, and as this COHB is unsuitable for oxygen transport, and the other one is one molecule of the CO2. Why the even less than 1% could be fatal? Because one molecule of carbon monoxide in the air that binds to one monomer, one polypeptide of hemoglobin molecule, that increases the affinity of the other monomers to oxygen, so that oxygen bound to these monomers are not released. I repeat here, when one molecule of carbon monoxide bind to monomer, means one polypeptide of hemoglobin molecule, that increases the affinity of other monomers to oxygen, so that the bound oxygen could not released. So that's what, in the presence of COHB, oxygen is unavailable. Okay, oxygen, that's what this form is unsuitable for oxygen transport. So because of that, because of this reason, there is further sorry, because of this, there is further decrease the availability of oxygen to the tissues. Then how do you treat this? Is administration of oxygen under high pressure that release the CO2 carbon monoxide toxicity, that is the CO. And the next type of is abnormal hemoglobin derivative is sulfhemoglobin. Sulfhemoglobin means here hemoglobin along with the sulfur. Okay, how this sulfhemoglobin has been formed means, when hemoglobin is acted upon by some substances like hydrogen sulfide, hemoglobin, when it reacts with hydrogen sulfide, which is formed due to intestinal bacterial action to form sulfhemoglobin. Okay, so here hydrogen sulfide, which is formed due to intestinal bacterial action, that could acted upon, that could bind with the hemoglobin to form sulfhemoglobin. And this sulfhemoglobin, it cannot act as oxygen carrier. Even this is also unsuitable for oxygen transport. and it cannot convert it back to hemoglobin. That means sulfur group irreversibly bound to hemoglobin. So it cannot be converted back to normal hemoglobin, and this sulfhemoglobin, the condition cannot be treated because it is irreversibly bound to hemoglobin, and patients with the mild degree of this are cynosed, and only the treatment for this alpha hemoglobin is we have to wait until all RBCs are destroyed as a part of normal life cycle. Okay, this alpha hemoglobin, this condition cannot be treated as it cannot be converted back to hemoglobin. Once sulfur has been attached to hemoglobin, is the treatment is we have to wait until that particular affected RBC has to be died as a part of its normal life cycle. Okay, patient with the mild degree of this are cynosed. The next one is the next abnormal hemoglobin is methemoglobin. Methemoglobin, it is an oxidized hemoglobin. Methemoglobbin, it is an oxidized hemoglobin. Here iron usually in hemoglobin remains in Fe+2 form, then but here in meth, if Fe+2 is replaced by Fe+3 to form methemoglobin. Okay, in the structure of hemoglobin, heme at the center, iron remains in Fe+2. If it exists in Fe+3, the so form structure we can call it as methemoglobin. But some amount of the hemoglobin is oxidized, okay, regularly by free radicals and hydrogen peroxides, which are generated during oxidative metabolism. Okay, as long as metabolisms have been taking place in our body, there is continuous production of hydrogen peroxide and free radicals. Those can continuously oxidize as Fe+2 to Fe+3. So Fe+2 becomes Fe+3 to, okay, because of this continuous production of free radicals and hydrogen peroxide, some amount of Fe+2 continuously oxidized to Fe+3. That means there is some amount of methemoglobin is continuously being formed. Okay, and that Fe+3 form, it has 5 valencies. Okay, so 4 valencies bound to nitrogens of pyrols, fifth one to histidine, okay, proximal histidine of globin. So there is no sixth valency for Fe+3. So Fe+3 cannot bind to oxygen. Okay, Fe+3. If in the structure of hemoglobin, if Fe+2 is replaced by Fe3, that is called methemoglobin, and methemoglobin is unavailable for the transport of oxygen because their iron exists in Fe+3 form. So in place of oxygen, a water molecule occupies a site in the heme of methemoglobin. Okay, in place of oxygen, the water molecule has been, oxygen has been replaced by water molecule in the structure of methemoglobin. So normally less than 1% of the methemoglobin is present in blood. Okay, being continuously produced, being these free radicals and hydrogen peroxides are continuously produced, those may continuously oxidize as Fe+3 to Fe+2 to Fe+3, but the total concentration of methemoglobin is less than 1%. How the level is maintained less than 1% being the continuous production of free radicals and H2O2 means because our RBC has, okay, because there are 2 mechanisms which has been operated in RBC that keeps the methemoglobin levels low. Okay, methemoglobin concentration is less than 1%. So but there is continuous production of H2O2 and the other free radicals are there. These H2O2 and free radicals, they can oxidize Fe+2 to Fe+3, even though irrespective, okay, even though the methemoglobin concentration is less than 1 is maintained in our body by the 2 mechanisms which has been operated in RBC. So what are those 2 mechanisms means? So there is decrease in the production of H2O2 or superoxides before they react with the Hb to form methemoglobin. So H2, can't stop the production of free radicals and superoxides because they are produced continuously being a part of metabolisms. But here, once they are produced, immediately they have been destroyed. They have been converted to other forms by the enzymes which are present in the RBC, that is catalase, glutathione peroxidase, and GSH, that is reduced glutathione. All these are these catalase, glutathione peroxidase are the enzymes which could act upon H2O2 and convert H2O2 hydrogen peroxide into water, thereby decreasing the production, thereby decreasing the concentration of H2O2. And even there is reduced glutathione is there. So that reduced glutathione also, which decomposes hydrogen peroxide. So ultimately RBC has this reduced glutathione, catalase and glutathione peroxidase. All these enzymes keeps which will destroy the H2O2, which will detoxify H2O2 concentration. As H2O2 production is, as its concentration is decreased, means what will happen? This Fe+2 cannot be converted to Fe+3. On other side, oxidation of hemoglobin is reverted by the enzyme Methemoglobinemia reductase. Okay, Methemoglobinemia reductase, which will convert methemoglobin back to hemoglobin. So as these two mechanisms are operated continuously in the RBC, methemoglobin levels are maintained in the body less than 1%, and any increase in methemoglobin that is more than 15%, that can be manifested as cyanosis. Normal concentration should be less than 1. If the level exceeds more than 15%, it is manifested as cyanosis. Okay, methemoglobinemia, because as the methemoglobin levels are increased, means because methemoglobin is unavailable for the transport of oxygen. Why? Because here ion exists in Fe+3 form. If the concentration exceeds more than 15%, which is known as methemoglobinemia. Methemoglobinemia is a term denotes increased concentration of methemoglobin in blood. So here the reasons for this methemoglobinemia means increased methemoglobin levels could be due to increased production of methemoglobin or due to decreased ability to convert it back to hemoglobin. There are two reasons for increased levels of methemoglobin. Either failure in the conversion of methemoglobin back to hemoglobin or due to its increased production. Okay, and this methemoglobinemia are of two types: inherited methemoglobinemia. The second one is acquired methemoglobinemia. Okay, there are two types are there. It could be acquired or inherited. So first one is inherited methemoglobinemia, which is due to deficiency of methemoglobin reductase. If this enzyme is deficient, what will happen? Methemoglobin cannot convert back to hemoglobin, thereby increasing the concentration of methemoglobin. Or due to the presence of hemoglobin variant, that is HbM. Okay, methemoglobinemia is characterized by increased methemoglobin levels in blood. Now what we are discussing, it could be of two types: inherited, acquired. Inherited one may be due to the deficiency of the enzyme methemoglobin reductase. In the absence of this, there is failure in the conversion of methemoglobin to hemoglobin. The other one is the presence of hemoglobin variant, that is HbM. And what is this HbM? It is a hemoglobin variant. Mutation of the amino acid histidine, which is attached to heme, is replaced by tyrosine. Okay, histidine amino acid has been replaced by tyrosine. That could result in the formation of abnormal hemoglobin, that is hemoglobin M. So this Hb, because as the hemoglobin has been replaced by tyrosine, which keeps iron in Fe+3 form. Okay, iron in Fe+3 form means that increases the production of methemoglobin. So because of the presence of HbM variant, HbM here histidine is replaced by tyrosine. Because of this replacement mutation, iron will be remain in Fe+3 form, thereby increasing the production of methemoglobin or due to deficiency of methemoglobin reductase. Now, how do you treat this inherited methemoglobin? Means by oral administration of a dye, that is methylene blue, that is 100 to 300 milligrams per deciliter, or by the ingestion of ascorbic acid, that is vitamin C, 200 to 500 milligrams per day. So by the oral administration of methylene blue or oral taking of ascorbic acid relieves the symptoms of inherited methemoglobinemia. So here these two decreases the methemoglobin to 5 to 10% and reverse cyanosis. So that's it about the inherited methemoglobinemia. And the second one is acquired or toxic methemoglobinemia. Acquired toxic, this may be due to ingestion of large amounts of the drugs like phenacetin, sulfonamides, chemicals like aniline disodium nitrochloride by the accidental ingestion of these drugs. Okay, these are toxic like phenacetin, sulfonamides, and aniline which may leads to high methemoglobinemia. So that's what this is called, acquired, and it may be due to deficiency of the enzyme glucose 6-phosphate dehydrogenase. Acquired may be due to ingestion of large amounts of the drugs, these drugs, or else may be due to deficiency of this enzyme glucose 6-phosphate dehydrogenase. So this enzyme glucose 6-phosphate dehydrogenase, in the deficiency of this, glutathione remains in oxidized form. Okay, because of this enzyme glutathione remains in oxidized form. It remains in the oxidized form. It cannot detoxify H2O2 to water. Okay, because of the deficiency of the enzyme, glutathione remains in oxidized state. If it in oxidized state, glutathione H2O2, it cannot convert H2O2, hydrogen peroxide, to water. That leads to accumulation of H2O2 in blood. H2O2 then oxidize Fe plus 2 to Fe plus 3, thereby increasing the production of methemoglobin. Now here acquired may be due to these reasons. Now the symptoms of this are cyanosis of skin and mucous membrane. In severe cases there is dyspnea and loss of consciousness, and even it sometimes leads to death because of lack of availability of oxygen. Now, diagnostic test, how do you diagnose this one is by spectroscopic analysis. Treatment of this acquired is in mild cases by oral administration of ascorbic acid. In acute and severe cases by intravenous administration of methylene blue. Okay, that's it about methemoglobinemia. Methemoglobin is one of the type of hemoglobin where in place of Fe plus 2, Fe plus 3 exist, that is unavailable for transport of oxygen. Its concentration is less than 1%. But here there is continuous production of free radicals and H2O2 in the metabolisms. They may continuously oxidize as Fe plus 2 to Fe plus 3, but level is maintained by the enzymes which are present in the RBC, catalase, glutathione peroxidase, and reduced glutathione, that is GSH, all will keep the H2O2 levels low, and by the enzyme the process methemoglobin is converted back to hemoglobin by the enzyme methemoglobin reductase. If there is increased concentration of methemoglobin, that is called methemoglobinemia, which is due to either increased production or due to decreased availability, ability to convert back to hemoglobin. So like that, there are two types are there: inherited, acquired. Inherited due to presence of hemoglobin variant HBM or the deficiency of enzyme methemoglobin reductase, and acquired may be due to ingestion of large toxic drugs or due to deficiency of G6P deficiency. Next one, coming to the myoglobin. The other one, heme containing protein, is myoglobin, and myoglobin is a monomeric protein. What about your hemoglobin? Hemoglobin is a tetrameric protein made up of 4 polypeptide chains, but a heme containing another protein is myoglobin. It's a monomeric protein, means heme with 1 polypeptide chain to form myoglobin. Now here it's a single polypeptide chain made up of 152 amino acids, and it's a low molecular weight protein, 15,500 kilodaltons its molecular weight. And mainly this myoglobin is it's a heme containing protein. Myoglobin is mainly present in the muscle, skeletal muscle, cardiac muscle, and smooth muscle. This myoglobin has more affinity to oxygen than hemoglobin. Please note down that here myoglobin, it's a monomeric protein, it's a heme containing protein, but it has high affinity to oxygen than hemoglobin. And here this myoglobin is called oxygen storage protein. It's a reservoir for CO2. It is known as myoglobin is called oxygen storage protein. Now here, why it is called? Because of more affinity towards hemoglobin, towards oxygen. When myoglobin is 90% saturated, partial oxygen PO2 in tissues is about 30 mm of Hg. Okay, at the PO2 level 30 mm of Hg only, myoglobin is 90% saturated. Why? Because it has more affinity to oxygen than hemoglobin. At this PO2, normally at this PO2, at this 30 mm of Hg, hemoglobin saturation will be only 50%. Okay, at 30 mm of Hg, hemoglobin saturation is only 50%, whereas myoglobin, because of its more affinity to oxygen, it is 90% saturated. And in severe physical exercise, the PO2 in muscles lowers 5 mm Hg, then the myoglobin releases all the bound oxygen. As I mentioned, myoglobin is an oxygen storage protein. So during strenuous exercise where muscle tissues lacks enough oxygen, then when the PO2 levels are falling down, then the myoglobin, which is present in the muscle, which releases oxygen. So severe muscle crush injuries causes release of myoglobin into blood from damaged muscles. Myoglobin concentration is increased in blood in severe muscle crush injuries, because as it is present in the muscle, any injuries causes to muscles increases the concentration of myoglobin. And being a low molecular weight protein, it is easily excreted in urine, so that is called myoglobinuria. So in severe muscle crush injuries, myoglobin from the muscle released into the blood. Okay, then as it is a low molecular weight protein, it is easily filtered at the GFR and can excreted in the urine. So myoglobinemia is followed by myoglobinuria. Myoglobinuria is a term denotes presence of myoglobin in urine. So in that time, urine becomes dark red in color. And even in myocardial infarction, myoglobin is released from myocardial tissues. So that's what increased this myoglobin levels is considered as the earliest marker of myocardial infarction. Okay, so so what you have to know about this myoglobin, it has more affinity to oxygen than hemoglobin. It's a monomeric protein. It's a monomeric protein having only one polypeptide chain, especially it is present in muscle, skeletal, cardiac and smooth muscles. It acts as oxygen storage protein. So at the 30 mm of Hg, at that level, PO2, hemoglobin is 50% saturated, whereas myoglobin is 90%. And during muscle crush injuries, there is dark red color urine is passed, because in the muscle crush injuries, myoglobin will be released into the blood and then excreted into the urine. So urine appears dark red in color. But in myocardial infarction, okay, in heart disorders, myocardial infarction, myoglobin is released from cardiac tissue, and so increased myoglobin levels in blood is considered as is the earliest marker of myocardial infarction. Okay, so that's it about the structure of hemoglobin, myoglobin. Till now we have discussed the structure of hemoglobin and the types of hemoglobin, derivatives of hemoglobin. Under derivatives, normal or oxy, deoxy and carbaminohemoglobin, and abnormal derivatives are methemoglobin, sulfhemoglobin and carboxyhemoglobin. Okay, so abnormal derivatives and normal derivatives help in the functioning of hemoglobin. How the normal derivatives oxy, deoxy, carbamine help in transport of oxygen and carbon dioxide. That is the primary function of hemoglobin and abnormal hemoglobins. And finally, we discuss about the structure of myoglobin. In the next class, we will discuss about functions of hemoglobin. How the primary function of hemoglobin is to transport gases, oxygen from lungs to tissues and carbon dioxide from tissues to lungs, and also hemoglobin acts as buffer. So in the next class, in detail, we will discuss about the functions of hemoglobin. So there only we will discuss about in detail oxygen dissociation curve. Okay, that is ODC curve, and what are the factors which will affect the oxygen dissociation curve. In that only we'll discuss the chloride shift, Bohr's effect and the effect of 2,3-BPG. All will be discussed in detail in next class. Thank you. I can now.